go. Anyway, so thank you so much for joining us. This is Dr. Monica Christmas, and you've got a number of titles, haven't you? Obstetrician, gynecologist, and director of the Women's Integrative Health Centre at the University of Chicago Medical Center, and director of its menopause program. So you're incredibly busy.
Yes, that is true.
Absolutely.
It's a good busy. It's a fun busy. I love what I do, so that always makes work easier.
Absolutely. And I remember when we first spoke, what you really lit up when we got to perimenopause. So what is it about perimenopause that really attracts you? That's so interesting for you.
It probably is because I've recently just gone through perimenopause myself, so it becomes very real, not just something that I'm talking about with my patients. But I actually initially had the menopause interest because in my training over 20 years ago now, I'm dating myself, we really didn't learn much about menopause in my residency training. And around the time that I was starting out in practice, my mom was going through menopause and she was having a horrible time with it. And she's asking me questions and I didn't know how to answer them. And she was, seeking medical care and really being made to feel that she was crazy. You've got anxiety, you have depression, and some of that is true because, and we'll talk about many of the symptoms that start to rear their ugly head with perimenopause, but anxiety and mood swings are part of it, but there's a reason behind it. And I think the part that was missing, at least for her, and it was heartbreaking for me to watch, was that she wasn't getting any explanations for why. And often these symptoms kind of just come out of nowhere, it seems like. And I think that's hard for us to manage. Like, well, there has to be some fix because I felt fine a couple months ago and now I don't feel good. So when we talk about like the symptoms, and it's related to these fluctuations in hormones. So just like when you were at the other spectrum of the reproductive cycle, right before you start to get menstrual cycles, there's those fluctuations, and people always talk about the mood swings that maybe their preteen is experiencing, or right before they get menstrual cycles. So same thing kind of happens on the opposite extreme. Because of these fluctuating levels, the ovaries are still making estrogen and progesterone, which is why you still are getting a menstrual cycle. But things are changing. The menstrual cycle may, for some people, they're lucky. They get shorter, they get lighter, they space out, and then they just gracefully go away. But for other people, they may get heavier, longer, even closer together before they go away. And then there's everything in between.
Yeah.
And the,
Did
you know,
you,
hot
did you
flash.
when you started to go through it yourself, did you recognize the symptoms in yourself? Because I know there are a couple of doctors here who are menopause specialists, and even they didn't realize themselves what they were going through.
Not. Of course not. You don't recognize things for yourself. I thought I had TB. I'm like, oh my gosh, I'm waking up with night sweats. It's tuberculosis, And many people with the pandemic, I've got COVID every day, checking their temperature to see if it's COVID. So.
Yeah, there's a TB.
Right. I've got tuberculosis. It's got to be that,
Yeah, that's the first logical thing that would spring to most people's minds.
Exactly.
Yeah. So when people present to you, do they are they joining the dots themselves, or is it they've just you mentioned before that people think they're going crazy? What do they say to you when they come in?
I would say 20 years ago when I was first starting out in practice that no, I don't think people were putting together the dots. Just like my mom necessarily wasn't putting together the dots because we didn't talk about it. There wasn't a lot of information. People didn't have things at their disposal. And unless you actually went to see a healthcare provider that was in tune to what was going on and can say, oh no, this is what's going on and this is how we're going to manage it, people didn't know. But right now, I think fortunately, it's a hot topic. There are many more resources for people going through menopause that they have at their disposal. So I actually, and I think people that are coming to see me now probably are specifically have sought me out. So I feel like now people are much more in tune with themselves. They've done their research, they're coming in and saying, hey, I think I'm in menopause or going through menopause. What can I do to help my quality of life be better?
Yeah.
And that's a testament to people like yourself.
With it's interesting actually when you say that people are sort of better informed now, because there's a I understand that from what I gather from people in America, Britain seems to be a little bit further ahead in sort of drumming a menopause gong and saying, we take notice of us, this is serious, you've got to be paying a bit more attention to it in the health service generally. But there's also, I mean, there's been a bit of a backlash too with people just sort of basically saying, oh, for God's sake, this is a natural thing. People have gone through this, since the day dot. What's wrong with you? Get over it. Do you find a bit of that in America as well? Do people feel almost guilty about coming to see you to talk about their symptoms?
Well, yeah, because it's so different. Everybody goes through, just when I describe the menstrual changes, right? So if you're one of the people where your periods are getting shorter and lighter, and then they space out, and then they just gracefully go away, you aren't going to have the same type of quality of life issues that the other somebody may have that's hemorrhaging every month, right? Same thing with hot flashes and night sweats. Some people will say, I get a few, I open my window or I drink a cold glass of water, and they happen maybe a couple times a week, and that's not as bothersome as somebody's feeling like they are having a hot flash multiple times in an hour. They're waking up 4 times at night drenched and can't get back to sleep. That's going to carry a whole different. So when people start talking to one another, if your mom says or your older sister says, what's wrong with you? Like, it was fine. You're such a drama queen. It wasn't that bad. Well, maybe it wasn't that bad for them, but
Yeah.
that doesn't mean. So I think that's where that variability in symptoms and that comes in really does play into maybe the shame, or I don't want to say shame, or the guilt that people have with coming in, because they think, I should toughen up. I should be able to manage this. Why am I having such a hard time?
Do they, though, by taking that sort of badge of honour, I'm going to plough on through this, are they potentially, putting their health at risk by not taking the symptoms seriously?
Well, the one part about it is, one, if you don't feel good, your quality of life is poor, then you probably aren't going to do all of the other things that are necessary for optimal health, like exercising. If you're not, they all kind of snowball into one another. Because if you don't feel good, if you're having these mood swings or maybe having depressed mood or anxiety, that's going to trigger. If you didn't sleep well because you had night sweats all night, that may play into why you're not exercising or why you're not doing other things that optimize good health. And really, there was a recent study that was published in the Menopause magazine, and it was more so talking about cardiovascular health during the perimenopause, but they related things to centripetal adiposity, so the weight gain that we start to see in our midsection. And with these hormonal changes in menopause or perimenopause in particular, is a time frame that they looked at, there was a steep incline of like weight gain. And so if we're putting on weight in the worst possible area here, that increases a lot of other health, medical comorbidities like cardiovascular disease and stroke and heart attack and all of those things that really women don't think about it as much as we do for men, but more women die from heart disease than all the cancers put together. And so it should be something that we think about. And because that incline is so steep around those perimenopause years, sometimes that weight gain happens and we like wake up and say, oh my goodness, I just gained 30 pounds in a year time frame. And it's hard to take 30 pounds off if you haven't started to employ these healthy lifestyles. So it's a long way of answering your question, but yeah, I do think these menopausal changes that are also related to the aging process but are accelerated in this time frame can really impact a woman's health if we're not doing something about it, right?
Yeah, it's interesting actually because we also, I mean, the heart disease, dementia, osteoporosis, those sorts of diseases. We always think of that. Oh, they're just old people. That happens to somebody else, not to me. Somebody in 30 or 40 years' time. And we also sort of tend to think, oh, there's somebody else there that I could admit that I wasn't paying any attention to. Sorry. We think that they're diseases of old age, but we are now living so much longer. Should we be starting to reframe perhaps the way we think about these symptoms? Because if we get things right, as you were saying before, the exercise and nutrition and those sorts of things in the early days, can we be healthier when we're 70, 80, 90 or 100?
And that's exactly the motivational speech I try to give to my patients, because sometimes when you start to talk about just healthy diet, it seems punitive, like, oh, I'm being punished. I didn't have to do these things in the past, and I was able to maintain a desirable or healthy weight. And it just seems like now everything, I'm having hot flashes, my body's changing, I'm being punished, my hair is going gray, my skin is wrinkling. And so that is the approach that I think is it has a better, people resonate with that of just overall health. I think on average, most people are living now until their early mid 80s. You go through menopause in your early 50s. So a third of the lifespan is spent in this post menopause phase. That's a large part of your life.
It
And
is.
so if you start to think about, well, how is it that you phrase it as, how is it that you want to live? Do you want to be in a nursing home with somebody else having to take care of you? Do you want to be able to garden and, drive, or do the, be lively in your, as we are getting older and better, I like to say. And I think when you phrase it that way, people are more apt to say, yeah, you know what? I want to put things in my body that are going to fuel me to greatness, or allow me to have the longevity and the livelihood that I want, and the autonomy to be able to take care of myself and live the way I want. And then that puts a different phase into the exercise portion of it too. How do I maintain my muscle tone so that I have good, strong, healthy bones, that I've got good cardiovascular health, but that I also have energy and I'm feeling good, not only just about, outer appearance, but what's going on my inside too. And so I do think people resonate with that message a lot better than just kind of the hardcore, eat well and, go to boot camp.
Yes, exactly. Because not every, especially as you say, if you put on 30 pounds, or as I have, I think I was adding it up the other day and saying to my husband, I think actually since having a child, giving up smoking and menopause, I think I put on around about 12 kilos, which is that's a whole baby. That's a whole pregnancy baby. The amniotic fluid, the whole thing. It's a lot. And now it's all sitting there, and it shouldn't be. So you sort of lose that sort of motivation. You feel that it becomes too hard. But it is so important to sort of, to start again, really, isn't it?
Yeah, I like to start to talk to people really, much earlier, even like in the 30s, really. In the 20s, nobody's going to really pay attention to you so much. You're, thinking, but I do think people in mid 30s are, because you start to, you're more stable, you're thinking about things, you might be starting to see your parents age or have medical things happening with them. And so I do think that's a good time frame, even just for a regular annual visit, of starting to talk about the changes that they may start to see over the next few years, and when perimenopause starts, because we really start to experience symptoms of perimenopause up to like 7 years before you actually stop getting your menstrual cycle and your end menopause. So the average age, as I said, is about 51 and a half, but the range is between 45 to 55. So by 55, 90% of women will have stopped getting a period. Well, if you start having symptoms up to 7 to 10 years before your period stop, it's not unusual in your late 30s, early 40s to start to experience some of those symptoms, like hot flashes and night sweats, or mood swings, changes to metabolism. So so starting to talk about those things in the 30s, are saying, do you exercise regularly? how would you say your diet is? Have you heard of the Mediterranean diet and all the benefits that one can have by adhering to this type of lifestyle? And so the more people hear it and are able to make changes to not just be healthier, but to maintain their ideal body weight too. Because nobody wants to buy new clothes or, well, they want to buy new clothes, but maybe not in a bigger size, right?
Yeah, yeah, exactly. Or like me at the moment, having them in the cupboard behind me and thinking, I'm not going to be fitting into any of them. 2 years of lockdown in leggings. I'm never going to get a pair of pants again, or not in the same size anyway. And ego will not allow me to buy a larger size one. So they're just going to have to sit there, which is a shame. But yes, it's an interesting one, isn't it? So when if we're trying to motivate people then, and we're getting them to look at the different types of things that they can actually do. You mentioned diet there as being an important one, and thinking about how you feel better inside yourself. I mean, I don't know what the statistic in the US is at the moment, but obesity here is around about 62 to 40% of the population are overweight or obese, and that's an enormous slab of people to try, and people sort of concentrate so much on the weight on the scales, but are you actually sort of saying in the end, don't worry so much about the kilos, but actually get yourself to a point where you're eating, you're feeling better, and then you'll be more motivated? Is that a bit psychologically perhaps a healthier way of looking at it, rather than constantly starving yourself and looking at the numbers on the scales?
Because it, didn't happen overnight, and sometimes we get so gung ho. Our New Year's resolution is that we're gonna go to the gym, we're gonna eat well, and people, they'll start out by doing, some really strict, harsh, diet that's, completely restricting their calories to, I don't know, one bean a day, and and an apple maybe, and some water. And then they start to do a very rigorous exercise program, and it's not sustainable. One, because they probably don't want to just eat one bean a day. I tell people, you can, a lot of these very strict diets, even with the most disciplined of people, you could probably do it for about 30 days, and then you start to fall off because it isn't a sustainable long-term lifestyle change. And I threw out boot camp before, because some people, you'll do this for like 3 months and it'll be hardcore, but even that, if you're not truly enjoying it, it won't be sustainable. So I tell people, just walk, get a good pair of walking shoes, walk, for start out with just 30 minutes every day. I don't care if you do it in 3 10-minute walks, you do it in 2 15-minute walks, you do one 30-minute, but just do that. And then think about 5 things that you could do differently with your diet. And I try to ask them, like, what do you eat for breakfast? What do you eat for lunch? What do you eat for dinner? What do you snack on during the day? Are you a big caffeine drinker? Are you a sweets person? And then we start to look at, what are 5 things that you could alter with your diet, with thinking about being plant forward, not that you have to be a vegetarian, but what are some of the things that you can start to do? And then once they master those things and start to see an improvement, then what else could we do? I'm a big proponent of Pilates. I think if there was ever a fountain of youth, it would be Pilates and yoga. A big part of that is because we are losing muscle tone, and any type of weight resistance exercise that we can do is going to be really beneficial. Even just as important, if not more so, than kind of the cardiovascular exercises, because of the fact that we're losing so much muscle tone. So any type of weight resistance activity is going to give us a lot of bang for our effort, and definitely should be part of that workout plan. So.
Yeah, yeah, absolutely. And also for the bones too. Do we think enough about our bones?
I don't think so. I think that I even sometimes, when I've diagnosed somebody with osteoporosis, right? So this is somebody that we've done the bone density scan on. You have osteoporosis. And so in my mind, it's more dire. I want to put you on some type of treatment so that we can reduce any more bone loss and protect you against having any type of fracture or morbidity or mortality that would be associated with a hip fracture in the future. And I have a hard time getting people to understand it. And it's probably because that's something that's hard to feel. Like my bones feel fine, I don't feel necessarily different in my body. I think it's easier when it's something that somebody can feel, right? Like I'm having heavy bleeding every month. I'm fine with getting the hysterectomy, or I'm fine with taking a medicine that helps me not bleed. I have horrible migraines. I'm more willing to take a medicine to help my migraines because I'm feeling bad. With, say, osteoporosis or bone loss, we don't actually notice the issue until we've lost so much that now we have a problem and it may be too late. So, I start to talk about the vanity part of it, because that's what motivates a lot of us to do things, is that, I ask them, did your mom have osteoporosis? Did they start to lose height? Did you notice that they started to curve over? Nobody wants to walk around with that curvature in their back. So I use those kind of tactics oftentimes to motivate people to do something about it, because I don't think that we give enough attention to bone health. And that hopefully will change as we talk more about, menopause and the changes that happen in our body. But yeah,
Yeah, I can't
you're
remember what
correct.
the stats are here, but the cost of fragility fractures in the UK is enormous, and it's one of the main reasons why people end up in nursing homes, because they break a hip, and the mortality rate from a broken hip is really, I can't remember, it's 20% dead within a year. I mean, they're really quite scary statistics.
Right. So when you talk, that's motivating, so I think a lot of times that's the approach that I go for. And then I do think people are listening and more willing to employ one of the treatment options. Utilize.
Yeah. Yeah, and it's not. I mean, my father had a broken hip towards the end, and literally he didn't. He was not out of that bed again. They did a hip replacement on him, but in the end, he was so old and so weak that he was never going to walk again. So he spent the last year of his life literally just lying in a bed, and that's not much fun. That's not the way you'd want to be spending your time, really,
No.
when you're mentally all there but you're physically not. It's not a lot of fun. But there you go. Incontinence. That's the other issue, isn't it? That we don't joining the dots of menopause and bladder issues as well. We don't often do that particularly well, do we?
No, and there's not even a good consensus. I'm actually working with two of my urogynecology colleagues, and we haven't written, we're in the process of writing it up, and hopefully somebody wants to publish it. But we did a systematic review looking at really trying to answer the question, are urinary symptoms related to hormonal deficiency due to menopause, or is it part of the aging process? Because we don't have a lot of agreement. It is included.
Here it's sort of like, I guess, almost taken for granted. I think they basically say if you've got leakage, if you've got a mild prolapse, estrogen, but not
yeah.
a use. Yeah.
Well, I think I think there's controversy of like what is related to menopause, or specifically what's related to estrogen deficiency, and what is related to the aging process, and it's blurred lines. So this term was coined a few years ago, the genital urinary syndrome of menopause, and people shorten it to GSM. And there's a whole gamut of things that fall underneath there. It's all the vulvovaginal changes, vaginal dryness, vaginal irritation, itching. Oftentimes, if you have vaginal dryness, that's going to lead to pain with intercourse. So that's included underneath that. And most people agree all those atrophy related symptoms absolutely are due to estrogen deficiency. And we do know if we supplement estrogen locally, those symptoms by and large will go away. But when we look at the urinary symptoms, there's some conflicting data even with the research, but people will still include some of those symptoms in. So most people will say urgency symptoms, recurrent urinary tract infections, potentially even frequency may be related to estrogen deficiency. And they sometimes will, in some studies, will show that they improve with using vaginal or local estrogen. But oral estrogen in the Women's Health Initiative trial showed that actually symptoms of incontinence and worsened, or for stress urinary incontinence and urge incontinence. And so there's been some other studies too that have kind of collaborated with that. And so then it kind of becomes, well, what is and what isn't. So we went to the literature to see if we could answer the question. And spoiler alert, I don't think we did. But certainly, like I said, frequent urinary tract infections, urgency does seem to respond to vaginal estrogen, and many healthcare providers will use that in women that are experiencing some of those symptoms, and they may notice some improvement.
Interesting, actually, that I wonder when you mentioned the Women's Health Initiative study there, and we'll come to that in a second. But I wonder if the reason why it didn't show such a great improvement in that one was because the women were almost
Falling over the pillow, right?
if the women were older and they started later on the HRT, different type of HRT that you would have today, so those sort of confounding factors that you might see a very different outcome if you did it on today's estrogen than the Premarin and the different types of estrogen back then, and starting younger and on a younger cohort.
Yeah, and it's surprising because even now, looking back, when as writing this paper, was trying to see, well, because with the Women's Health Initiatives, you said it was just, they looked at Prempro and Premarin, which is, orally taken. They didn't look at any transdermal options. They didn't even look at that, that's conjugated equine estrogen, but they didn't look at other types of estrogens either. And so, I wanted to see, well, were there other studies that did head to toe comparisons, right? Did they do, estrogen cream versus the estrogen ring versus oral estrogen, whatever. And there's not a lot, really wasn't. So I think that's the hard part in trying to not only really having good quality studies that compare treatment options, and even the outcomes that each study looked at is different. So it's like opening a whole bag of worms, because you've got one study that maybe evaluated their treatment outcome using certain standards, and then you have 3 other studies that used a whole different thing. So not only were the treatment modalities different, but the outcomes that they used to assess success were very different too. And that's very difficult to be able to collate the data and compare and contrast. So I've been working with Dr. Martha Hickey in Melbourne. She initiated this COMMA initiative. It's the Core Outcomes and Core Outcomes in Menopause, and the outcome is that the purpose of that was to develop a standard set of core outcomes for menopause studies. So we did one set for looking for studies that would assess treatments for vasomotor symptoms, and a whole nother set for what are the important outcomes when you're assessing treatment options for the GSM symptoms. And so initially it was we did systemic reviews. So I spearheaded the systemic review for the GSM part of it. And then we wrote it up, and then kind of had a Delphi survey of all the major stakeholders, women that have gone through menopause, people in research, people in pharmaceutical industry, other experts in the menopause field, and came down to what a consensus was on what the core outcome set should be, and then published that. And so you could certainly do more than those outcomes that we recommended based on standard of care and literature, but you at least have to use those. So I think studies moving forward, if you employ those outcome measures, it should be easier for us to assess and compare treatment options. But right now things are a little bit of a mess.
Yeah. Oh, it's interesting. It's nice to see you doing a collaboration, especially with Australians. That's always a good thing. Yeah. The Women's Health Initiative study. I mean, this is the elephant in the room that we haven't addressed so far. HRT and its safety. People still are relatively concerned about HRT and whether or not they should or they shouldn't be taking it because of breast cancer risk. What are your thoughts? What do you tell your patients?
Well, you said it perfectly earlier that the average age, the women were older. So the average age of the women in that study was about 64. We already said that the average age of menopause is about 51. And so these women were well past their final menstrual period. Many weren't even symptomatic. So the purpose of that study was to see if hormone replacement decreased cardiovascular risk. So it wasn't even assessing whether it helped with alleviating bothersome symptoms. It was purely, was this going to help prevent against cardiovascular disease? So they took all comers, regardless of what was going on with them. And certainly at 63 and a half, 64, there's probably some underlying medical comorbidities already. And so it's no surprise that, in the midst of the study, people started to have strokes, have heart attacks. Breast cancer risk went up as well, or association with breast cancer went up. And so there was one arm of the study that was looking at the estrogen and progesterone, and then there was an estrogen arm. The estrogen and progesterone arm was stopped initially after about 5 years, and then the estrogen alone arm was stopped after 7 years. And of course, it was a huge frenzy. Everybody, providers were scared to give estrogen or give hormone replacement therapy. Women were stopped abruptly on it. Some were scared to take it. Other people were like, it may be bad for me, but I'm feeling good on it. And now my doctor won't give it to me and I'm miserable again. So there was this, whole turmoil and upheaval related to it. And then when people took a step back and said, you know what, let's kind of stratify the results. Let's look at the younger women that were closer to their final menstrual period. And that's where this timing hypothesis that people talk about comes in. So if you are within 10 years of the final menstrual period and under the age of 60, what were the outcomes for them? And actually, starting people on it earlier, they actually did have better outcomes, and the same risk was not associated. And probably, unless you have some contraindication that we wouldn't have given you hormone replacement for anyways, it's actually probably safe and may even have that cardiovascular benefit that we were looking for in general. And so the pendulum is swung back now to saying, you know what, in the right person, and there's a large amount of people that fit into the right person category, hormone replacement therapy is absolutely one of the best treatment options for managing bothersome vasomotor symptoms. It's the best option, can be a great option, I should say, for managing those genital urinary symptoms. And specifically for those, if that's all they're having, we can just use local estrogen, which has less systemic absorption and is even safer to use. And then any women that are going through menopause early, premature menopause, they went through menopause earlier than age 45, should be placed on hormone replacement therapy for protection against cardiovascular risk, bone health, even for protecting against cognitive decline. And they should stay on it until they would have reached the natural age of menopause. So those are some of the indications for using hormone replacement therapy.
You mentioned there, the majority of people that are suitable for it. Are there any? Because obviously the question that we often get here is that I've had breast cancer. Can I have HRT? The quality of my life is so poor now. Am I precluded? Is it always an outright no, or are there times when it could be considered?
If they, certainly it's a no if they've had a tumor sensitive or hormone sensitive tumor. I think that even for them, even and the most miserable person suffering from their vasomotor symptoms would agree they don't want their breast cancer recurrence either, right? For local, where it becomes a little bit more controversial though. So I think everybody would agree with oral estrogen. If you got and whether it be breast cancer, ovarian cancer, uterine, if there's a hormone sensitive tumor, then you're not going to give somebody hormone replacement therapy. But could you give them vaginal or local therapy? Does that confer the same risk that systemic dosing would? And so most of the literature shows that it's probably okay to use. Now, what we try to do first is to use something non-hormonal to manage those symptoms. And if not, then we can come back and say, hey, would be using a low dose to manage some of those vaginal symptoms be safe? There's a newer class of drugs that are in, at least in American FDA, phase 3 trials with the FDA. So hopefully within the next couple of years, they'll be on the market. But they're a class of drugs called the NK3 receptors, receptor antagonists. But in the same area of the brain that that sends signals to your ovaries to make estrogen. When your ovaries have stopped functioning and they've gone kaput and they're not making the estrogen, the brain recognizes that and starts to scream to make more estrogen. And so that FSH, the follicular stimulating hormone, shoots up significantly with menopause and the estrogen level falls. So the lower the estrogen level is, the higher that FSH goes. That same area of the brain that recognizes that decrease in estrogen, also that decrease in estrogen seems to increase these other, the candy neurons they're called. And so if we can block the release of those candy neurons, you actually minimize hot flashes and night sweats to a similar degree that hormone replacement therapy does. So it is going to be really a game changer to be able to have that new class of drugs on the market and be able to offer them to patients that either don't want to be on hormone therapy or can't be on it for some reason. So right now, the only thing I have to offer them is there's certain antidepressants that can help minimize hot flashes and night sweats. Gabapentin is another drug that can sometimes help. There's a blood pressure medicine, clonidine, that has some modest, improvement. Using things like cognitive behavioral therapy have also been shown, or hypnosis have been shown to have some efficacy as well. Sometimes we try to use a bunch of those modalities to see if we can help in somebody that's really suffering.
Well, that's true. You do need a toolkit, really, don't you? I mean, if you're talking about for insomnia, they have CBT now as well, don't they? For managing your flushes and things, they have CBT. The diet, the nutrition, the exercise, all of those sorts of things are very important. But you mentioned there as well dementia. Now, this is one that's getting a lot of attention at the moment with Lisa Mosconi and people like that working on neurological decline and estrogen receptors in the brain. Where do you think we stand at the moment of you were saying before, people who went through early menopause should definitely be on HRT as a preventative for dementia, but people going through at the average age, is there also a brain protective effect? Do we know?
Yeah, and the answer is probably not yet, and hopefully soon. It's not an indication to put somebody on hormone replacement therapy for prevention of cognitive decline or dementia. And there have been some trials that have actually shown that there can be some increase, not necessarily causation from the hormone replacement therapy, but so I don't think we know enough. But definitely. Eating well, exercise, staying active, keeping our minds active, can be helpful. So when we're talking about all these lifestyle modifications, I mean, even 7 years in a row, I think now, or 6 years at least, the Mediterranean diet has been voted, best diet internationally. But it has been shown that people that adhere to a Mediterranean style diet, they actually have less cognitive decline and less dementia too. So when we, in addition to the healthy bones and heart health that we talked about before, so there's lots of, motivating factors to get people to eat well or eat a plant-based diet, we should say.
Yep, and lots of nice omega-3s, which also brings us then to another topic. Your centre does take a very holistic approach, and as you have made very, very clear with the diet, the exercise, and all of those sorts of things. Supplements. This is the other thing that people are always interested in. What can I take? Are there any that we should be taking? Are there any that actually are shown to work? Basically, yes. Vitamin D. From vitamin D to black cohosh, what do we think?
Right. So if we're talking just supplement, we'll go to, I'll save the supplements to manage vasomotor symptoms for separate conversation. But so if we're talking about just overall health, is there some supplement that I need to be taking or vitamin that I need to take? I tell people I prefer for you to get your supplements through the foods that you are eating. And so even, yesterday I was counseling a patient she was osteopenic, so not quite osteoporotic yet, and really wanted to know what she could do health wise to help maintain and improve her bone health. And so she said that she had a really difficult time swallowing pills. She's got some esophageal issues. And so I said, but you do you have shouldn't have an issue swallowing. Well, let's look at dietary things. So I keep a list of foods that has calcium equivalents. So I show her the list and I'm like, let's look at the foods and do the equivalents, because you may not need to take extra calcium or vitamin D if you're getting then through the nutrients through the foods that you're eating and you're exercising and doing those weight bearing exercises. So I think that's the best way to get the nutrients, is just to be eating well, eating whole foods or foods that we recognize the ingredients in, eating more plants than anything else, and watching portion control. Unfortunately, in terms of the menopause discussion of what supplements help minimize vasomotor symptoms, those pesky hot flashes and night sweats, when you look at randomized controlled trials, so I'm throwing all of the hormonal supplements under the bus right now. So black cohosh, chasteberry, evening primrose oil. I'm trying to think of all the things that people, come in and ask
Red
about.
clover.
Red clover, right? All of, if you give half the people the black cohosh or whatever supplement, and the other half of the people a placebo or sugar pill, initially what happens is everybody says they're feeling better. I don't think I'm having as bad a hot flashes. And then after a couple weeks, nobody feels better. So there seems to be some placebo effect, that we all feel like if we're doing something healthy and good for ourselves, that there's a benefit. But then as time goes on, we don't. If somebody comes to me and they're taking something and they feel good on it and they feel like it is, and I'm not going to take it away, then great. But most people have said, I tried that already and it didn't help. What else do you have for me? The isoflavones, or the soy category, if that isoflavone or soy can be broken down to a metabolite called S-equol, that definitely does seem to have some benefit in having some improvement in vasomotor symptoms. But only about 30% of North Americans, at least, are able to break it down to that metabolite. So for the vast majority of people that are taking a soy supplement, they probably won't notice an improvement or a difference.
Yeah, just
So
eating it out like an expensive vitamin tablet. It's an interesting one though, actually, because the cost of these is huge, and the way they market is just extraordinary. And it's like, take this magic pill and you'll be fine in a couple of days, or eat this diet full of phytoestrogens. I mean, can you eat your way out of your hot sweats? Is it possible to actually do that if you eat a very soy-rich, phytoestrogen-rich diet? Is that a possibility?
weight loss has been associated with decreased hot flashes and night sweats. So certainly to get weight loss, you do have to eat a healthy diet and you need to exercise. But there hasn't been any specific diet that you should follow that's going to make your hot flashes and night sweats better. But weight loss has actually been shown to decrease hot flashes and night sweats. So to me, they go hand in hand. But I think if you overall feel better too, that helps as well. And so, yes, eating a healthy diet and exercising regularly, building that into your everyday routine is when we exercise, we release all those happy endorphins that antidepressants mimic. That's why people talk about that runner's high, or, you get people posting their workouts and they're so excited every day, they post their workout on social media. And those of us that maybe aren't working out every day are like, oh my gosh, why do we have to see, them on their Peloton every day? But it's because it makes them feel good. And so, I tell people, initially, if you're not doing these things, it is going to be hard. But it takes about, what do psychologists say? It takes 21 days. We'll give it 30 days to set a pattern. So treat yourself like a kid. Make yourself do it. Build your life around the exercise, not the other way around. Like, this is when I'm going to exercise and everything else gets built around it. And, people will say, oh, but it's been a pandemic. I couldn't go in the gym. And I was like, I'm not going to accept that. I have a yoga mat in front of my bed. I have 2 bruised toes because I keep tripping over the weights, but I have a set of 5-pound weights, 3-pound weights, and 2 pounds. I've got a foam roller and some yoga blocks. And YouTube has a phenomenal range of like videos that you can pull up. And so I, will pull up, the yoga Pilates videos and still have been able to do it. So they say, okay, yeah, all right, you're right. I could do something.
You win.
You got me. and it does, 10 to 15 minutes of something is better than no minutes at all. So I tell myself, even we have to be kind and gentle with ourselves. Even on my most exhausted day, the days that I've been in surgery all day, I still say you could do something for 10 or 15 minutes. I try never to look at the elevator. I walk up the stairs. Even if there's a close parking space, I park at the back of the parking garage. There's all these like little things that we can do to motivate ourselves to.
Yeah, and I think that with lockdown, that's been one of the big killers. It's what we in Australia call the incidental exercise. You're walking to your bus stop, walking to your tube, walking to to go and get your lunch or whatever it is. And then when you're at home for 2 years, all of a sudden you're going, I haven't walked anywhere. Which is
To the refrigerator.
greater, and that's about it. In sort of summarising, then, what's your take-home message for people as they approach menopause? What's your message?
That it's a phase of life. It's not bad or good. It just is. And I think that is really where issues come in, where people put a bad connotation to things. It just is. And I even did it for myself. I was comparing at the time that I started having symptoms, I was about 45. And I was comparing my 45-year-old self to like my 25-year-old self. And that's not ever going to be, it's not a winning comparison. Like, it's never going to be fair. And so I try to like redirect people's mindsets of saying, you know what, if we're lucky enough to live long enough to reach menopause, you're going to go through it. And so how do we live our healthiest, best life at this point? And it's almost kind of like life coaching at that point. It's like, let's talk, what are this, because there's a lot of stressors at this age too. People are taking care of aging parents. You talked about what you went through with your father. If you have children, many of them are leaving the household and going to college or coming back when you thought that they were going to, be out. But the job market has been such that sometimes these children are coming back. We didn't think they were. But there are a lot of stressors at this time of life. And right now, the last few years have been in the pandemic, but also going through these hormonal changes too. So really putting stuff into perspective of saying, what are you doing for yourself? What are you doing that's positive? What are you doing that cultivates and brings you joy? And how do we really just embrace this stage of life that we're at? And if you are having symptoms that really are impacting your quality of life, let's talk about treatment options. Do not feel like you failed. Hormone replacement therapy, if you decide to go on that, does not mean that you are weak and that you took the easy way out. It does not mean that at all. To me, you would treat your high blood pressure, you would treat your migraine. This is a medical condition too, so let's treat it. If I have options that are going to make your quality of life better, we can do that. And then we reevaluate these things every year. And then once we've treated, what are you doing also that are just the healthy things that are going to allow you to age gracefully?
Yeah, absolutely. It's interesting you mentioned that it's a medical condition, because that's the other argument as well, isn't it? That that people say you're over medicalizing a natural phase of life, but you're saying no, it's a deficiency. Let's treat it.
It is, and everybody, like we said, experiences things differently. But I wrote a blog a few years ago, and I wrote a bunch of them, and this one was the most read. It still is, and when people come in, I'm still surprised. But it was called "The Mental Side of Menopause," and that part of it, if you are not able to function in your day-to-day life, right? Your personal and your professional relationships are suffering because of your legitimate menopausal symptoms, and that's a problem. It isn't something that we can just write off and say, get over it. And many people are, some people tend to swing on the sad side where, everything kind of makes them cry, or they feel sad. Other people have more anger and they really aren't able to control it. That's problematic. And we can help manage that. So not only do they feel more like themselves, but their relationships aren't suffering. And it's real. I have people that come in and say, I'm on the verge of losing my job if I can't get this under control,
Yeah.
or I've pushed everyone away. I get so frustrated. I get angry. My siblings don't want to be around me. My spouse or my kids don't want to, or I've alienated myself from my friends. And I feel lonely. I feel bad about having done that. I don't know what's going on with me. I feel like I'm going crazy, right? That's and you sometimes it's hormone replacement therapy. Sometimes it's a mood stabilizer, and they come back in and I get hugs. I'm like, well, I didn't create the medication, so I can't, I'm not that brilliant, but people are really appreciative that, hey, my quality of life is back. I can get on with the business of life, and I can do all these other things that I need to do. So.
Yeah, and that's really that's, I think, probably one of the most underrated areas is the mental health aspect of it. I did a survey a while back, and of the thousand or so people who answered it, the highest rate, the hot flushes and night sweats were about 60%, but it was nearly 90% that had their anxiety, low mood, those kinds of things. It was really distressing for them.
40, and it's worse in perimenopause. Up to 40% of women can experience anxiety issues during that perimenopause transition. And it can be even higher in people who have had a history of anxiety, of depression in the past. Even if they've been well controlled, like it hasn't been an issue, they can get a recurrence in that perimenopause transition. And then and I know we're running out of time, but the last thing that we didn't mention too, that I find that people are reluctant to talk about is decreased libido or sexual dysfunction. And so, and that too is something that we can talk about. And it's really, if it's the vaginal dryness that's causing the symptoms, then using a vaginal moisturizer and a lubricant or vaginal estrogen is a very easy fix.
Yeah.
Sometimes though, it's more, I don't want to say mental, but it's not just that there's dryness or pain. It physically, as I feel different, and then we have to employ some other techniques of kind of helping them get over that
Yeah,
change.
the psychological aspects of it as well. Yeah. Brilliant. Look, thank you so very, very much for that. That was really informative, and I think we covered an awful lot of ground, really.
I think so too. Hopefully it was helpful.
It was, absolutely. So thank you, and hopefully we'll speak again sometime in the future.